Hi, everyone. Welcome to Working Alongside Refugees and Mental Health. My name is Sara Buckingham, and I'm from the University of Alaska Anchorage, and I'm helping to lead the WARM project.
Hi everyone, my name is Jordan Snyder, and I was a part of the WARM project, got involved when I was doing my clinical psychology internship up at the Alaska VA.
Hi everyone, my name is Issa Spatrasano. I'm the Program Director and State Refugee Coordinator at Catholic Social Services, Refugee Assistance and Immigration Services Program, and we were the nonprofit partner on this project.
Hello everyone, I'm Elizabeth Mangini, and I became involved in the WARM team during my master's program at the University of Alaska.
So the WARM project really came out of what was an identified problem in our community. And the identified problem we saw in our state is that we had limited quality mental health care services for refugees in Alaska. And as the Refugee Resettlement Program, we saw this just in service provision. We saw this in referrals to mental health providers. We saw this in challenges with getting timely appointments. We saw it with challenges in insurance, but we also saw this documented in a 2015 needs assessment that was done here in the state of Alaska. And what we saw in that is that the need was definitely there. WARM was a hopeful solution to that very problem. And so the Working Alongside Refugees and Mental Health program really was intended to help us solve that problem at a state level. And so really, what was the impact of WARM? So really the overall goal was to improve mental health care for refugees living here in the state of Alaska. And that needs assessment that had been done in 2015 really indicated in a number of things that indicated that there were a number of challenges to improving the mental health care services. Some of them being practitioner competence, practitioner confidence, and practitioner willingness. Another thing that we saw was practitioner action, like actually taking the step to take on refugee clients. We found in this WARM project that practitioner competence, confidence, and willingness did improve. So how did we do it and how did we get there? My colleagues and I are going to try to describe how we did it, how we got there, and hopefully how you could redo this project in your own community. So just a little bit about the context of where we are. So Alaska is the largest state in the United States. It covers a very vast geographical region. The Refugee Assistance and Immigration Services program that I work in and oversee is the only resettlement program in the state. And we serve a number of arrivals across the state. Majority of the population lives here in Anchorage, where we're located, but over 30% of our caseload lives in different communities, including the Mat-Su, which is about 1 hour away, and even further away, 7 or 8 hours away. And so whatever we did, we knew we needed to make it accessible and really try to improve statewide service as well as our local community. And so in addition to that, one of the things that is kind of interesting about Alaska is while we're small and mighty and we resettle a small number of refugees to our state, we have a very diverse caseload, that includes a number of different languages, a number of different countries. And so currently in our state, we are serving individuals from over 24 different countries. And so what that really meant is whatever we do in the WARM project shouldn't specialize in one cultural group or one religious belief or one sort of need or niche. It really had to be broad, far-reaching, and really allow providers to be able to provide services to different kinds of refugees in a number of different contexts.
So as we were developing WARM, Issa approached me as she was taking on this role as our state refugee coordinator and the new director of our resettlement center in Alaska. And we sat down and we identified different partners who could be involved in this project, thinking about the assets they could bring to our team as well as each of their needs, keeping those in mind as we developed WARM. Of course, we have the university represented, and the university was able to provide content knowledge and some technical expertise that we needed to do the project, as well as personnel, so both faculty and students you're hearing from today who worked in this project. Then of course, RAISE, our resettlement agency, our nonprofit, provided lots of knowledge about the needs of refugees in our community, and then we're able to house the grant funding that funded this work. Our state psychological association was also involved, as well as the many mental health care practitioners who became involved with WARM serving refugees along the way. And then we also had many funders involved in this project, community partners who believed in the work that we did, and we'll speak to those throughout our presentation. So what does WARM actually look like? we designed WARM to be responsive to the needs of mental health care practitioners in order to help increase their competence and their confidence to serve refugees. And so we put together a series of CE eligible trainings, meaning that our providers could get continuing education through our state psychological association for their involvement in the trainings. We provided those trainings with no strings attached, so everyone from graduate students up through seasoned practitioners could participate. And then we also provided a series of resources to connect folks to other people in their community who serve refugees, as well as resources related to mental health care for refugees. We then sought to increase the number of refugee clients being served by helping to match clients with practitioners. And then, of course, we, being researchers, we were doing a program evaluation to make sure that our project was working the way it should, looking at practitioner satisfaction as well as outcomes associated with our network. And so I want to speak to you briefly about what that evaluation looked like, as well as our foundational training. We planned on evaluation from the start, and so we developed a short survey that we could administer to our practitioners over time. It was consistent so that we could track progress in WARM over the years. We kept it very short and then also incentivized it so practitioners would actually participate, administering satisfaction surveys after every training that we did, but then also measuring provider competence, confidence, perceived barriers to providing care, as well as changes in actions towards providing mental health services to refugees throughout the course of WARM. Our foundational training was presented by both Issa and myself as an in-person 7-hour training focused on the foundations that practitioners might need to get involved in this work. Issa presented information on forced migration and resettlement in Alaska in particular. And then I provided information about mental health care practice and evidence-based practices for our refugee population. We ended up having 32 practitioners participate, ranging from graduate trainees up through psychologists and folks in every stage of their training. And people participated from across the state, even traveling 6 to 7 hours to be part of our first training. After that first training, we found that practitioners were quite satisfied with the training itself, and they expressed increased interest in serving refugees. They were also had more competence and felt more confident to be able to serve our refugee population. However, we didn't see a change in action. They didn't indicate that they were more likely to serve refugees as a result of the training, in part due to many barriers that they became aware of from the training and that certainly continue to exist. And so my colleague, Jordan, is going to speak to what we did with that information.
So based upon that information, we decided that it would be really good to conduct a needs assessment, which is what we did next. The goal of the needs assessment was really to inform WARM design as we continue to design it, as well as determine what future trainings should consist of for our participants. So what we did with the needs assessment was we sat down with 13 mental health practitioners in Alaska who had experience serving refugees. And we sat down with them for 30 minutes, did some interviews, and then also did some thematic coding based upon that information. What we found as a result of this is that practitioners were really interested in getting more training in interpretation and how to do that well, and integrate mental health services into in a situation where you need interpretation, specific help with understanding particular therapies such as narrative exposure therapy, and then also in conducting specialized evaluations like asylum evaluations that might be relevant. In terms of network design, we found that practitioners were really interested in the connections that they could form with other people working with refugees, and then also more knowledge about refugees, and then also practical experience working with refugees. We also discovered that there were particular barriers, especially for those folks that were in private practices, especially in terms of interpretation and the costs of interpretation. They were willing to provide those services pro bono. However, they couldn't pay for interpretation out of pocket. What we did next, based upon this information, was we ended up going for grants for further trainings and then actually conducting those follow-up trainings. And so what we did is we got a grant through the Alaska Community Foundation for $15,000 that allowed for these future trainings. And so what Sara and Issa did is they condensed that foundational training into an online 2-hour on-demand training that people would watch before they attended either of the follow-up trainings. And then we had 2 follow-up trainings, one on interpretation and then another one on narrative exposure therapy, to really help our practitioners feel more confident and competent in these areas. Each time we had new people participate in all of these workshops, and we found as we continued the evaluation that competence, confidence, knowledge, and willingness to serve refugees continue to increase throughout these experiences. And then next, we really wanted to target that interpretation difficulty and also start matching our therapists that we were training up with refugee clients, which I'll talk with you now about. And so we're really fortunate to have great community partners, and a lot of our large agencies see a majority of our refugee clients, including Providence Family Medicine Center and Anchorage Neighborhood Health see a lot of our refugee clients. However, there are still those clients that don't have insurance, but they can be seen by the providers that we're training. And so what we did is we got a grant from the Alaska Mental Health Trust for $10,000 to cover these interpretation costs for WARM practitioners, that if they were willing to see folks, then the interpretation would be covered. And so we got that grant, started matching refugee clients to WARM practitioners, and so far we've matched 5 refugees with those practitioners, which has been really great so far.
Hello, everyone. Now here we are in present times, and we're learning to adapt in this new COVID environment. And it came just when our WARM community was really growing, and we had great momentum. And just a couple weeks, everything changed, and so certainly there were bumps in the road. We'd already started planning for a 4th training on vicarious trauma and resilience, and we were really looking forward to our inaugural dinner panel with refugee health promoters, and unfortunately we had to just cancel those events. Additionally, as mental health providers transitioned to telehealth, we just had fewer clients in need of interpretation services. So things were just changing all around. And additionally, the way in which we communicated with one another also changed too. And so in-person trainings and network meetings, it just became too risky. However, even with the bumps in the road, we didn't want to lose our momentum or our ability to stay connected. So we brainstormed and we found ways to move forward. We found that we could capitalize on national conferences that moved online. And one of the first ones on deck was the North American Refugee Health Conference. This was a 3-day conference that focused on issues that are relevant in refugee healthcare. Attendance at that conference also came with 17 continuing education credits, and we were actually even able to help provide some funding for that training if they had attended prior trainings. So we hoped that it would help them gain in their competence and their confidence, but also we wanted to incentivize their training a little bit. We were also planning to reschedule our panel with the refugee health promoters. Some additional modifications include we're developing a lending library where clinicians can borrow books and other tools to use during their work with refugee clients. And then we also built a WARM website as a one-stop shop for our community. This really helped us to stay organized and allowed us to showcase our work. And additionally, the website's a great tool for our provider network to keep them informed, but also to put out cancellations as well. We're also redirecting our efforts in creating outreach and psychoeducational materials, and we're redirecting some of the grant funding to help us with translating our materials for languages that are appropriate for our clients. So with that said, we've had some transferable lessons. When we adapted our trainings, we asked what our community partners needed, and we truly value their experience, their skills, and their perspectives, and they were an integral part in adapting, making adaptations in this new environment. It's vitally important to maintain transparency among all of our partners, let them know that what we're working on at all times, and then communicate with them just early. And just as we are adapting, so too are they. So we really have to be responsive to their capacities, their needs and desires, as well as build flexibility into the network as these change over time. And then we must consider sustainability from the outset, and we have to address barriers at the levels that they occur. However, we understand that not every barrier can be handled at the individual level. We acknowledge systemic change needs to occur, and that advocacy at all levels is important. So with that said, that brings us to the end of our presentation. If you have any questions or comments, or you'd like to reach out to the team for more information, please contact Dr. Sara Buckingham at the email and numbers provided,